On to speaker introductions, we have two speakers today. First, Dr. Devin Oller is a primary care and addiction medicine physician and has served one of the first rural health leadership fellows and chief resident at Massachusetts General Hospital before coming to UK. He is an associate program director for the University of Kentucky Internal Medicine Residency Program and is an investigator for the NIH-funded Healing Community Study. If you've been coming to KY Open, you all know Dr. Oller, so welcome, Dr. Oller. And then Dr. Liza Bastin is a resident physician in the primary care program and addiction medicine track at the University of Kentucky. She plans on practicing primary care in London, Kentucky upon graduation. And Dr. Bastin has an adorable puppy named Paprika. So welcome to our speakers today.
Thanks so much, Sean. So we don't have any financial disclosures. What we hope to cover and what we think is a major gap in the literature and our training is that there's many behaviors, including gambling, internet gaming, binge eating, that are significantly impacting the well-being of individuals, especially those living with substance use disorder. But the research is lacking in what the best approaches are to both evaluating and managing those particular behaviors. And these quote behavioral addictions actually overlap a lot of the times with and impact the treatment of people with opioid use disorder and other serious illness. Slide. So by the end of this session and our Q&A, we hope that you'll be able to identify a couple of key characteristics and what's happening in the brain that's shared across these problematic and unhealthy behaviors, that you'll be able to compare and contrast the diagnostic criteria of gambling disorder and substance use disorder, where is there overlap, where are there differences. And then we'll be able to explain to clients or patients the pros and cons of management options available to those with these problematic behaviors. And we hope that by identifying the problematic behaviors more readily in individuals seeking or already engaged in opioid use disorder treatment, we'll be able to better share resources and treatment options and get people the help that they need. All right, so I'm going to start in a little bit of a weird place. So I'm going to start, I want us all to imagine that we are on a desert island. Maybe it looks a little bit like this. We've got some nice clear water around it. And on the desert island, we're sort of just dropped there. And I want us to think about sort of what the first couple things we would do if we were dropped onto this desert island. So I'll give you a moment to just sort of reflect on what your first steps would be as you're in this predicament. And I think a lot of people would probably think about basic things like, let me get some food, let me get some water, let me get some shelter, something to make sure that I feel safe. And those are sort of driven by physiologic drives, things that are happening in our brain, and actually a couple of particular brain centers that actually nudge us towards doing things that will allow us to acquire water, acquire food, acquire shelter and safety. Let's say we're on this desert island and we're starting to get a little bit hungry. And so we're looking around the island and seeing what's available. And we see that there's a tree with some coconuts up top. And we try to shake the tree and nothing happens. And then we just sort of run full speed at the tree and headbutt the tree and a coconut falls down. And we say, aha, that's how I obtain coconuts and things to eat. And so we're able to enjoy that coconut. And the next day, instead of trying to shake the tree or climb up the tree, we do the same thing. We run full speed ahead and ram the coconut tree and a coconut falls down again. And we repeat this behavior because what it's doing is it's feeding sort of that physiologic drive that we have for food. And that we've learned that when we headbutt the coconut tree, a coconut tends to fall down and we're able to get that. Now that seems weird, right? We would want to be trying other things before ramming our head against a tree. But at the same time, when we learn that that is something that is going to happen every time we do it, we start to do it again and again. And so then maybe we're having difficulty sleeping on this desert island, and we find this plant that if we sort of rub a little bit of the leaf on our gums, we notice that that helps us fall asleep. And then each day we start sort of rubbing a little bit of that leaf on our gums, and that allows us to fall asleep, and we feel good and we feel safe. So we start getting this learned pattern again of I need to make sure that I get this leaf so that I can fall asleep. What we're doing, and this is a great example of it, what we're doing is that we're learning how to be in our environment. Each of those behaviors, whether it's ramming our head against the tree or rubbing a leaf underneath our gum that we don't know anything about, are the result of us learning this is something that's going to help with one of our physiological drives. Okay, so we can go to the next slide. So when people are dealing with acute stressors, when they're under duress, we as physicians, but others as well, can take different perspectives to try to understand what's going on. We've talked a lot in the KY Open lectures about the disease perspective. This is what a patient has, right? It doesn't define who they are. There's a clear sort of definition of what is happening in the brain when there's a disease process. There's treatments that impact sort of that disease process in the brain, and people get better with those treatments. We haven't talked much about sort of the dimensional perspective of looking at folks who are struggling or under duress, but that's basically what a patient is. And a great example of that, even though it's sort of fallen out of favor, is intellectual quotient or IQ, right? This is something that is somewhat fixed, and while people with low IQ can accomplish amazing things and are definitely an inspiration, there is sort of a fixed spectrum of things that they're going to feel comfortable doing. And outside of that spectrum, they're going to become uncomfortable. The life story perspective is what we encounter, and grief is a good example of that. How we respond to losing someone really close to us changes sort of how we navigate the world. And then lastly, there's behavior. And we'll spend a lot of time talking about behavior today and how this perspective can be important in evaluating and managing folks living with substance use disorders. But the way that I think of all of these things together is if this is a sort of a window into what's going on in our clients' lives, each sort of pane, each of that window is one of these perspectives. And we're not going to get a full picture of who they are and what they have and what they're doing and what they're encountering until we're looking through each of those four paintings. Next slide. So focusing on behavior, behavioral choice is resulting from learning, right? When we run our heads against a coconut tree and the coconut falls, we might do it again because we've learned that there's a reward associated with that behavior. And that in itself is going to create drives to try to obtain more coconuts or go from there. All right, next. So those drives can be physiologic drives. That's what we started talking about on our desert island. These are the things that are going to kick in if everything else has gone haywire. We're still going to have these drives for food, for water, for sleep, for sex, for safety. And the reason that we have that is firing sort of deep in the brain in what's called the dorsal striatum is sort of our brain's autopilot. It's responsible for making sure that we are doing these things that keep us alive. Okay, so there's signaling that occurs within that sort of purple part of the brain, the dorsal striatum, that is sort of guiding us to satisfy these particular drives. But there's also psychological drives, and that's marked by sort of this grayish black dots there in the nucleus accumbens and the ventral tegmental area. there's not going to be a quiz on that later, but the important thing is if the dorsal striatum is the autopilot, these other brain centers are sort of like the air show pilot, right? They are seeking excitement, adventure, something new, something different. And each time they're able to achieve that, there's a dopamine rush into those areas. And that sort of allows us to, those rewards allow us to figure out what in our environment is going to satisfy some of our psychological drives, the things that we feel we need to be happy, to be well. What's really interesting, and this is shown throughout some of these problematic behaviors that we're going to talk about, is that early on with the development of these behaviors, there's going to be a little bit of a decrease in our physiologic drives, our drives for food, water, sleep, as we are pursuing more and more these psychological drives. And so mostly what's happening is we're sort of being guided by those dopamine surges. We get a reward for that activity, and so we're going to pursue that activity more. But at some point, it sort of switches, and there's more and more activity happening in the brain centers that are associated with physiologic drives when we're doing the behavior. So whether that's gambling, whether that's internet gaming, we're starting to see the parts of the brain fire that we would normally see fire when we're pursuing water or food. And so those psychological drives almost become automatic. Okay, so this is the really important part of this, because this is where we start running into issues and challenges with just navigating life, because this autopilot has sort of been hijacked by that behavior. Next slide. So we're going to be talking about 5 sort of specific behaviors. Not all of these are in the DSM-5, which is sort of our main textbook and sort of lists the criteria for mental illnesses, but all of them impact the well-being of the patients, the clients that we see. And so we're going to start with gambling, and Dr. Bastin is going to talk to us about that. I'm going to go through sort of a brief overview of internet gaming disorder, binge eating disorder, compulsive buying, and some sexual behaviors as well. But I'm going to kick it over to Liza to talk a little bit about gambling.
Hey, thanks, Dr. Oller. Okay, so introducing gambling disorder. I want to start by defining what is gambling disorder and when does a behavior become a problem. So gambling in itself is defined as placing something of value at risk with a hope of getting something of greater return. So you hope to put $5 on a horse at Keeneland and hope to get back 20 or 30 or 40, and multiply the risk that you put into it. So when that becomes a pathological disorder, is defined by persistent, recurring, maladaptive patterns with your gambling behavior. And it's associated with impaired functioning, a reduced quality of life, higher rates of bankruptcy, divorce, relational problems, even law problems, stealing money, embezzlement, and legal issues that come along with that. So if you want to go on to the next slide, please. Going back to the textbook that Dr. Oller mentioned, the DSM-5, it defines gambling disorder as a persistent, recurrent, maladaptive gambling behavior. And it actually lists 9 criteria, and you need 4 of the 9 to be diagnosed with this disorder and not have an associated manic episode, which is a different psychiatric condition that can make you kind of like hyperactive in a way. So if you don't have the manic episode in 4 of these 9, so if you want to switch slides for me, here's the 9 criteria. So you just need 4 of these. So you could find yourself frequently preoccupied with gambling. You're thinking about gambling. You're reliving your experiences. You can't focus on other things because you're planning your next gambling episode. and your thoughts are just kind of wrapped around it. You could have increased needs to gamble, increased amount of money in order to achieve the same effect. So kind of starting to build this tolerance level that you need to go higher and risk more to achieve the same effect that you used to have with gambling. Another one is has made repeated unsuccessful efforts to limit, cut back, or stop. Number 4 is restless, irritable when attempting to cut down or stop. So problems associated with trying to cut back. Another criteria, using gambling as a way of escaping problems, or when you're in a bad mood, really relieving stress. So it's a way you react to feeling, anxious, depressed, helpless, using gambling kind of as an escape from whatever you're going through in the moment. Let's see the next one, gambling and losing money. Often gambles another day to get even. So feeling like you're chasing your losses. Oh, I had a bad day, but I'm going to make up for it the next day and the next day, and kind of feeding into the cycle of like chasing a behavior from the day before. Lying to family members, therapists, friends about your extent of gambling, trying to minimize it, not being honest or forthcoming about the extent of your gambling. And then our last 2, jeopardizing or loss of a significant relationship. So spouse, going through a divorce, losing a job, a career opportunity because of your gambling. So major impact in your life, either socially or professionally because of gambling. And the last one, relies on others to provide money to relieve a desperate financial situation. So having to borrow money to pay off your debts, essentially from gambling, whether that's legally, illegally, kind of that act of desperation to kind of make ends meet with that. So that is the 9, you need 4 of the 9 to officially be diagnosed with the gambling disorder. I'm going to switch slides now. Thank you. So epidemiology. So a meta-analysis, that's basically a big study that looks at a lot of other studies. So looking back at other studies from the past 2 decades, it's found to have a lifetime estimate of the population, about 1.6% to have this gambling disorder. And then also identified people with problem gambling, but they don't meet that full criteria that we just talked about, was about 3.9%. So altogether, even if you add those up, less than 5% across the North American population. However, it was suggested that gambling exposure could influence the rate. So as more and more casinos are being built, gambling, more avenues are increasing to large groups of people, maybe that rate's going to increase over time. And then studies also looked at specific populations to see who are these people, are there risk factors, and have found that military veterans were actually more likely to have gambling disorder, as well as young adults, teens, particularly males, are more often. So yes, Dr. Oller, much of gambling is online now too, so having more access widely available. I'm gonna go to next slide. Okay, prevalence, incidence of gambling disorders seems to be higher in individuals seeking treatment of substance use disorders. So if we went back to everyone in North America, the prevalence of both the disorder and problem gambling, not meeting disorder, is still less than 5%. But then you take that and look at just people that have another form of substance use, whether that is opioids, smoking, alcohol, any other substance, you're now 5 to 30. So I think it's a pretty significant jump in your lifetime estimate of having a gambling disorder. So that kind of goes back, why are these things seeming so related, and what are some similarities in those brain pathways that Dr. Oller started talking about with our reward system and how our brain is programmed to work. And then, like we said, with increased opportunities to gamble, some research expects that we could see these numbers going up in the years to come. Next slide, please. Here's a Gamblers Anonymous survey. This is really easy to pull up online and kind of go through if you're in a clinic setting, or if you have a friend or family member, you kind of want to get an idea of, hey, do they have a problem? Is this gambling disorder? This QR code is here. If you want to scan it, it'll take you directly to the link for this survey. So a lot of these questions are aiming at those criteria that we talked about before, losing time from work, affecting your relationships, losing sleep, obsessive thoughts, borrowing money. One of the questions I think is pretty sensitive to try to gauge where people are at. Have you ever gambled to escape worry or trouble? So are you using gambling as an escape? I think is a pretty good if you had to pick one question to kind of screen out. Is this maybe becoming a problem for someone? Next slide. Clinical characteristics. So like we said, usually this begins younger population, teens, early adulthood, males more likely than females. However, in women that have been studied with gambling disorder, they seem to progress quicker to get into more of the severe consequence risk. However, women are more likely to seek treatment and recover than men are. And some of the triggers that people have with these gambling disorders are advertisements, emotional state, emotional liability, using gambling as an escape from different scenarios, from stress or depression. Okay, next slide. Functional impairment. So many suffer significant social and professional occupational consequences. Like we mentioned, you start to have intrusive thoughts, urges, your thoughts become fixated on the gambling. You start having the relational problems, but also this loss of trust within different relationships, different situations. And then you can start seeing the financial difficulties, the legal difficulties, poor life satisfaction, and then also really related to a lot of depression and maybe even suicidal ideation as a result from the gambling behavior. Next slide. And that kind of brings us into the psychiatric comorbidity. So studies have shown that gambling disorder as a psychiatric condition is often associated with other psychiatric comorbidities. So anxiety, depression, substance use disorders, like we mentioned, the smoking, alcohol, other drugs. And a study showed over half of the Gambler Anonymous participants have reported either alcohol or drug use, which is pretty high when you think over half people also struggle with alcohol or drug use. Studies have also showed an increased rate of attention deficit hyperactivity disorder. That's ADHD. If you think of the classic picture as a child at school not being able to focus, being hyperactive, but also that persisting throughout beyond school later in life and having that lack of attention and focus. You see more mood disorders, anxiety, in addition to personality disorders, obsessive compulsive, narcissistic, and even some antisocial personality disorders can be linked to the gambling disorder. Okay, next slide. Family history. It's interesting that some studies have shown 25%, so 1/5 of people with gambling disorder have a first-degree relative. So that's a parent, a sibling, or a child who also has gambling disorder. So that could suggest, is this something genetic that makes them more susceptible to having this disorder? Is it that they were exposed to it by a close family member? It's a learned behavior pattern that they've acquired by having a close relative. So kind of like, is this part of their genetics or just part of a learned behavior? And then having a parent or gambling with a gambling disorder is associated with a 3.3 times higher risk of developing one. So it's really interesting to think their relationship there. Okay, go on to the next slide, please. So pathophysiology, so that's like how this is acting upon the brain. And that really goes back to those pictures that Dr. Oller started with, those neurobiological pathways and how those pathways are changed by the gambling behaviors. So studies have found changes in serotonin metabolites. So serotonin is one of the metabolite in your brain that helps regulate a lot of your mood, your feeling of calm, pleasure, being at ease, maintaining your mood, really. Finding that to be changed with pathological gambling disorder. And those relationships between substance use disorders and gambling have shown similar changes. So you can get into the cycle of tolerance. So you're gambling at a certain level you build this tolerance to it that makes you want to gamble more and risk more money and do larger bets. And then when you stop, you can go into this withdrawal from it. And then your brain kicks in this craving and anticipation of when you're going to gamble next. And then going back, but you've already built up this tolerance, so it's going to go higher and even higher. So it's this chronic relapsing course, this cycle that Dr. Oller alluded to. And it's very similar brain pathways as we see people with substance use disorders that struggle with opioids, or alcohol, or any other substance that can cause this cycle of tolerance and withdrawal and craving. So I think it's really interesting that we see those same changes in this behavior, gambling, without putting a physical substance into our body, like a drug or alcohol. So still similar brain changes are found. And then kind of going back to that genetic component, there are studies that show that twins might be more likely. So having some potential genetic component, pathological gambling, alcohol abuse, both twins being more at risk. So maybe some people are more genetically susceptible to being caught up in this pathway of tolerance, withdrawal, and the craving, and back and forth. Next slide, please. So that brings up this whole idea of this natural addiction, which is kind of what this talk is centered around, this behavior, this addiction pattern, and these changes in your brain that are happening without putting another substance into your body. So it's natural, it's your body producing these changes. So like Dr. Oller is going to talk about some of like overeating disorders, gaming, like sex disorders, things like that, that involve the release of natural opioid peptides in the area of your brain that kind of trigger this cycle. And then studies have shown that these gamblers have also exhibited more activation of these axes. So the HPA axis is hypothalamic, pituitary adrenal axis, as well as the changes in the pathways for reward. Okay, next slide, please. And this is kind of going back to dopamine. Dr. Oller had mentioned dopamine briefly. So it's part of those pathways in that it's a hormone that your body makes that releases and kind of binds as a signal to activate some of those pathways. So studies have shown that maybe dopamine plays a pretty large role in pathologic gambling. There's been reports of patients with Parkinson's disease, which is typically like a motor type disorder that we often see in older people. They can start having lots of slowing, cognition problems, lots of tremors is a classic symptom you see. But one of the medications for Parkinson's actually increases the level of dopamine, which helps with the symptoms of Parkinson's. But then these people that are on these Parkinson's medications actually start to develop gambling problems in their late adult life. So we're talking 60s, 70s, 80s, people that have never had a gambling problem before, they pick up one after starting treatment for their Parkinson's, which is really interesting, that interplay of dopamine. And that's similar of other drugs as well, such as a drug for restless leg syndrome that affect dopamine levels. Okay, next slide. And this kind of just reiterates some of the pathways in your brain for reward, judgment, emotion. You see the nucleus accumbens that Dr. Oller mentioned, and how dopamine really acts on those pathways. So you can see on the right, the dopamine being released, and then, being attached to receptors to really activate these pathways. So this is kind of just more of a visualization of what we've talked about that really works together to create a rush of pleasure. If you want to go on to the next slide. So then finally ending on treatment. Okay, so we know that this is a disorder. We know it's impacting life. We know that it's causing dysregulation in our brains. So what are we going to do about it? That is the big question right now that a lot of studies are focusing on. So there's some evidence for therapy, cognitive behavioral therapy, trying to help work through some of this. There's Gamblers Anonymous. Here's the hotline. if you know anyone that's struggling with gambling, and the website to reach out to try to get that person some help. However, we need more data to know, what's the best way to help these people. So if you want to go to the next slide. There are some medications out there, but unfortunately, there's not the magic pill that, oh, you have a gambling problem, we can prescribe this and this is going to cure you. So no medication actually has like an FDA indication for gambling. However, interestingly, some opioid antagonists, so your naltrexone and your nalmefene, can appear to potentially help. So that's actually working as a blocker to the opioids that your body's releasing to try to stop some of that cycle of your tolerance, withdrawal, and craving. So it's interesting that there is some promise there. And then some studies have shown antidepressants to potentially help as well, to try to help regulate the mood. But really, we need more data and more research studies to kind of see what's the best way to attack this disease. And then last slide for me is just a public health approach. So making it widely known, working on limiting advertisement for gambling, minimizing outlets, new casinos, really trying to decrease triggers, really enforcing the legal age of gambling, since we know that younger people are more susceptible to becoming really like addicted and developing this disorder. So really just working from a public health approach to trying to raise awareness and do what we can to prevent this from spreading. So that's all I have on gambling disorder. If Dr. Oller wants to pick it up.
Sure. Why don't we pause here too and see if folks have any questions for you about gambling disorder? Pharmacotherapy? I think one. Yeah. So an important point that I'll make here is similar to, we think about sort of stimulant use disorder in our folks with opioid use disorder. The presence of a gambling disorder or any of these other problematic behaviors with an opioid use disorder is not a reason to hold off on giving appropriate evidence-based care for that opioid use disorder or alcohol use disorder. So if somebody is struggling with both opioid use disorder and gambling, we would still want to use some of our first-line therapies like Suboxone or buprenorphine or methadone. You see that naltrexone is an option here. Again, I think given that we have some better data with buprenorphine and methadone for retention and treatment, reduction of overdose deaths, I would still lean towards that in our folks with opioid use disorder and gambling. But let's take an alcohol use disorder patient who's also struggling with gambling. I think that's a great candidate to use naltrexone to potentially help with both of these pathways. Similarly, if people have clear mood disorders where antidepressants are going to be first line, trying to initiate those early on to address how much sort of that mood worry issue is driving the gambling behavior. Awesome. All right, let's move forward. So we're going to talk a little bit about internet gaming disorder, one of the newer disorders in the DSM-5. So this might look like a bunch of just little red and blue dots, but it tells an important story. So the blue dots are people who who just regularly game, but do not have an internet gaming disorder. And the red dots are those individuals with an internet gaming disorder. And what they were looking at is sort of how much activity is happening in certain parts of the brain for folks who just game here and there versus those with a true internet gaming disorder. And they saw significantly more firing, more activity in that physiological drive part of the brain, sort of our autopilot part of the brain in folks with an internet gaming disorder. So you see more of that red and at higher levels in the putamen, which contain some of those key autopilot centers in the brain. Whereas for folks who are regular gamers, but not having an internet gaming disorder, you see more of that activity in the reward pathway. Again, pointing to the fact that when we're starting to develop disorder, there's been sort of this change in what's happening at a brain level, and forcing us to sort of see gaming or see this behavior as one of the key drives, the key things we need to satisfy to get through our day. Right. So next slide. These are the DSM-5 criteria for internet gaming disorder. And you'll see this mirrors a lot of what we saw with the gambling disorder and a lot of what we see with our substance use disorder criteria. So if we think about sort of substance use disorder criteria as having persistent cravings, impaired control, and sort of complications of use, those 3 C's, we also see impaired control here. We also see that physiologic sort of dependence and tolerance and withdrawal with internet gaming as well. And most of that's going to be mood related symptoms. It's going to be irritability, anxiety, sadness when not participating in the games. There's going to be preoccupation, and that's more of that craving, right? That constantly thinking about the urges to jump onto these games. And then there's continued use despite these other complications, whether it's misleading others, using as an escape, reducing their interest in other activities, or risking other opportunities as a result of gaming. Advance. So the interesting thing is that, and this speaks to sort of the prevalence of internet gaming disorder, is a ton of people are not going to meet any of these criteria. So that's what this graph is showing. The vast majority of folks in 4 different studies looking at the prevalence of internet gaming disorder saw that over half of people who are using internet games on a regular basis are not going to meet any of these other criteria. A good chunk, so maybe 1 in 5, are going to have maybe one of these criteria, but getting to a true diagnosis around sort of 4 or 5 criteria, really we see a pretty low prevalence of this. That said, it's still a significant issue, a significant concern, especially with the expansion of internet gaming. Next slide. So what do we do in terms of management of this disorder? So we're going to come back to this a couple of different times, but CBT is sort of the key component, cognitive behavioral therapy, for a lot of these particular behaviors. And specifically what we focus on in CBT therapy for folks with IGD is going to be modifying maladaptive thoughts. So, what are the attitudes, what are the beliefs, what are the biases that they have about the game that initiate and maintain excessive gaming. So that might be a thought of, that world in my internet game is better than the current world, right? And that might be a challenging thought to go through, given everything that we're dealing with right now in the real world right now. But that's an example of a potential maladaptive thought. Another goal, so foster coping strategies to reduce some of those withdrawal symptoms, the irritability, the anxiety, the depression that come on when not gaming. And a lot of that is going to be working on trying to step down the level of gaming so that there's not sort of this abrupt cessation and really severe symptoms that are driving somebody back to the behavior. And then the third component of CBT is developing social skills and new routines, including physical activities that are in the place of gaming activities. One really great sort of mutual support organization is gamequitters.com. And they go over a lot of these basics of what treatment will look like for folks who are looking to get into treatment. They will have a couple of online groups that folks can jump onto to get support and hear sort of the lived experience of others who are going through this. And so I think that that's a great resource to share with clients where this is suspected. Medication, unfortunately, we don't have a ton of evidence. I would similarly, like with gambling, make sure that we're not missing other independent mood disorders, other independent substance use disorders. And specifically for gaming, I would think about sort of tobacco or nicotine products, caffeine, the psychostimulants as sort of the thing that might be reached towards to try to extend the time that folks can stay engaged with those games. So it's important to address those. And occasionally we're seeing folks get some benefit from residential or intensive outpatient programs that are focused on reducing gaming and trying to improve some of those other skills and routines. Next slide. So we're going to go through a couple of different just example CBT exercises to just dive a little bit deeper and help you guys understand what things might look like for clients who are dealing with a substance use disorder and one of these other difficult behaviors. So behavioral activation is sort of one of the main hallmarks of cognitive behavioral therapy. And what I would instruct somebody to do is sort of take out a piece of paper, and the first step in behavioral activation is just listing activities that they do in a typical day. And a good way to sort of separate that out are sort of pleasurable activities, routine activities, and necessary activities. And that gets at, right, a little bit of like psychological drive versus physiologic drive. So if they're writing down all their activities and you're seeing where is eating, where is like sleeping, where is like pooping, like where, like just those basic drives they have to satisfy. And if they're not writing those down, then we can remind them, okay, where does that fit in to your day? The next step, once we have all those activities listed, as we sort of separate them out in terms of how difficult it is they perceive to do those activities. The next step would be sort of separating out morning, afternoon, nighttime. Let's start scheduling a few of those easy activities so that you are developing a routine where you're doing something positive that moves you in the goals and the directions that you want to achieve. And then they have to work on completing those easier activities. And then you're going to get back with them and see, how did we do on that? What activities do we need to adjust? And can we add in some medium or some harder activities into that as well? So a great example of this is, if you wanted to do behavioral activation for somebody with regards to their dental health, you would not start by saying, okay, I recommend that you floss 3 times a day, right? Like you're not going to get anybody on board with that. But maybe if you say, okay, you're brushing your teeth once a day, can we schedule another time, maybe in the morning instead of the evening where you find it easiest to brush your teeth? Maybe can we schedule right after breakfast, you also brush your teeth? And once they're able to achieve that and they're building their self-confidence and they're building their sense of self-efficacy, then you're moving on to more advanced activities. And maybe then, flossing once a week, and then flossing every other day, and then flossing daily. If anyone actually does that. But so that's an example of behavioral activation. And you could see how that's adaptable to gaming, where you might have them do, one additional activity outside of gaming for that first week that you're working with them, and then begin to slowly expand that as they're seeing benefit to breaking away and doing something different. So areas that we still need to explore and research when it comes to internet gaming disorder. A big one is that this is a really narrow scope right now of that the criteria cover. It's games on the internet. It's not other internet related behaviors. So it's not internet pornography. It's not internet doom scrolling or Twitter use or Facebook use or anything like that. It's gaming on the internet. There's also other games outside of the internet that have that potential to develop into problematic behaviors down the line. We also don't know if people can function at a good level with a controlled level of gaming rather than sort of the maladaptive levels of gaming. And we're still uncertain about what risk factors are at play in folks developing internet gaming disorder as well. So we don't have that same level of robust evidence that, say, gambling does when it comes to family or twin associations or other substance use disorders. Next slide. There's certainly, similar to gambling, public health interventions that are being considered and tried out in various settings. This just came out a couple weeks ago, where China actually tightened limits for young people to play online, and actually banned any school night play as well. And you can see that there's pros and cons to these sort of interventions. On the plus side, you are limiting exposure to people who might be at higher risk when we don't really know what those risk factors are, to something that could be an issue down the line. On the other side, you are maybe causing more stigma and making it less likely that somebody's going to reach out for help because of fear of punishment or other things if it's found out that somebody is engaging in this behavior. And so we've seen with opioid use disorder and other substance use disorder, the powerful impact that stigma has throughout our communities. And I think we need to be really hesitant before sort of implementing broad-based interventions like this without an eye towards how this might stigmatize folks. Next slide. Yeah, John, so I think that's a really good point. He put in the chat that lots of video games now have a gambling components in them. And so Europe has regulated some of those things. I think the other thing is, and we'll talk about compulsive buying down the line, like a lot of internet games also have a component where you can like buy goods and stuff. I think like different clothes or like outfits for your avatar, and that those prices, those costs can quickly escalate and cause significant issues as well. But it plays into that same sort of dopamine pathway. Loot boxes and in-game items. Okay, this is like a whole nother world that I don't really know. There are a couple of really great cognitive behavioral therapy workbooks. One that I like, it has a really dumb name, but I find it to be pretty effective, is 10 Days to Self-Esteem. And I know Dr. Lawful loves that one as well. So, and that's nice because it has instructions for how the client can go through that exercise on their own, and has the work pages that they can make copies of as well. Okay, next slide. So binge eating. So briefly, just an overview. We know that it's actually the most prevalent eating disorder among adults, so about 2% prevalence over one's lifetime. Unlike anorexia nervosa or bulimia nervosa, binge eating disorder has less discordance, so less of a difference between women with the disorder and men with the disorder compared to other eating disorders. And it's typically characterized by these binge eating episodes, distress about binging, and but not the behaviors that you see with anorexia or bulimia, where there's purging activity to compensate weight as well. We know that this particular eating disorder it has a high risk of developing other medical issues down the line. So diabetes, high cholesterol, blood pressure issues, sleep apnea as well. Next slide. Surprise, CBT is the most established treatment for binge eating, and there's really good response rates. So about 50% responds with a complete cessation of binge eating after conclusion of CBT. Many stay in remission after that. Guided self-help, which is often facilitated by some component of training, either via the internet or in person. It was not as effective as in-person CBT in one study a few years back, but certainly a reasonable thing to trial. And that's like, printing out some of those workbook pages and having them go through that. Pharmacotherapy studies, so this is an active area of research. We know that there's a few agents, topiramate, naltrexone, some stimulants, lisdexamfetamine is one that might be helpful in reducing binge episodes. But this is certainly something that, if we're having issues where somebody's not responding to CBT or guided self-help or groups, I would consider getting them to a specialist to do that therapy. However, just like we talked about with some of our other problematic behaviors, if there's a reason to be prescribing some of these agents for an independent mood disorder or substance use disorder, there's a great opportunity for overlap for affecting both of these processes with, say, naltrexone. All right, so I think a really good, we're going to go over 2 CBT exercises for binge eating. This is one of them. And this is sort of our pro and con list, almost like a cost benefit analysis that we talked about in our MI workshop. So reasons for stopping and reasons against stopping, and you'll have sort of the individual either have a copy of this or even just divide a plain piece of paper in half and have a plus and have a minus on each of those columns. And you want them to spend some time sort of thinking about reasons for stopping and reasons against stopping. Like we talked about with the cost benefit analysis, you can then go through and sort of add or subtract things. So suggest to them, if there's something obvious that they didn't write down, trying to see if they sort of can self-identify that issue. You can also go through sort of short-term and long-term reasons for stopping as well, to hopefully have them see that reasons against stopping are typically short-term reasons, and reasons for stopping are typically longer-term and more durable. So this is a great starting point, and at least allows you to begin to tap into a little bit of the what's motivating somebody in this behavior. Next slide. And then to dive a little bit deeper, this is very similar to sort of ABC model in motivational interviewing or SMART recovery. And this is sort of the behavioral chains worksheet. And so what this might look like is you have a consequence. So they might say, I had a binge episode this past Saturday. And then you sort of walk them back and say, okay, let's rewind the clock. What do you think sort of set off that episode? And they might say, well, I had an argument with my sister or with my brother. And so you write that down on that first circle right next to Q. So you have had an argument in that first bubble, and then had a binge episode in the last bubble. And then you're going to walk through each of those sort of chains of action between cue and consequence. So that might look like, okay, so you had an argument. What were you feeling right after that argument? Okay. And they might say, I just like so frustrated. Like I want my sister to understand I'm trying to get help for this. And she just doesn't understand where I'm coming from. Right. And so you might write down there frustrated. Right. And so being frustrated, what were some things that you thought about to get out of that feeling, to get out of that really difficult emotion to deal with? And they might say, I thought about sort of calling a friend. And then you would write, thought about calling a friend. What caused you to decide not to call that friend? Didn't want to bother them, right? It was late on Saturday. So didn't want to bother them would go in the next one. And you would go in each of those steps until you got to that consequence. And what that allows you to see with the patient is both those dysfunctional thoughts that are at play, like didn't want to bother a friend when the reality is that friend probably would have wanted to know that they were in crisis. But you can also see that there's so many different steps where this chain can be broken, right? Where we can intervene, where we can make a difference. And having them sort of play that back allows you to begin to see with them what interventions might be helpful. And so that's the next step, right? What strategies would we use to break this behavioral chain? And the more that they can come up with those, the better. And the more that you can tie that to those reasons for stopping the behavior that they went through in that first step, that helps as well, because you're tying that action item to the motivation, to the driver of why they want to make a change. So hopefully that makes sense. Any questions about the worksheet? We might go over a similar one next week as well. Compulsive buying. All right, next slide. So interestingly, this has been written about for a really long time. So one of the first reports of it was in this sort of seminal psychiatric book published in 1913, describing a series of different cases. But one of them was an individual who just kept on buying things. And they thought it was sort of curious and maybe part of a psychiatric condition. But this is an issue that's been around for as long as there's been sort of marketplaces in our society. So next slide. And what it is it's this preoccupation, that almost that craving or that urge with buying or shopping. There's frequent buying episodes that sort of satisfy that urge. But despite temporarily satisfying that urge, there's then sort of more overpowering urges after that. In fact, a lot of the times with the buying behavior, once they have that good, once they have that service or whatever, they don't derive much pleasure from that actual object, from the actual thing that they bought. It's that act of buying, of finding something, of finding a deal, of getting the deal, of getting the item, all those different steps that is really causing that surge in dopamine. We start to run into obvious issues with that, right? So there can be psychological issues, social, occupational, because of the amount of time and money that goes into these processes. There can certainly be financial problems. And this is commonly occurring in folks with other serious mental illness and substance use disorder. Younger people are more prone to develop compulsive buying. Many people with compulsive buying behaviors actually buy for others or never use the goods. And when they're sort of bidding on items, sort of getting into that gambling component and the dopamine surge that comes with that, they often do so anonymously. So they're not in it for sort of fame or to actually use any of the goods. It is that process itself that becomes compulsive, that is starts to be seen as almost this physiologic need. It's not in the DSM-5, and there's not a ton of agreement about what the criteria are across different research studies. So unfortunately, we don't have a ton of data to inform what are the best steps in management, but we do have some hints at what might be helpful. Next slide. And those hints come from this cycle, right? So if we have this psychological drive and distress when we're having urges to buy and poor mood, and we see that there's this huge surge of dopamine when we're actually able to find and buy those goods and feel, even though it's transient, that relief and pleasure that comes with it. We see that there's a couple of areas where we can intervene here. Next slide. So group CBT is highly effective in this population. And we can think about why that is, right? So a lot of there's this sort of shame associated with the buying behavior. It certainly causes other issues in family relationships or personal relationships. And so being able and being around folks who are dealing with some of the same issues can be hugely helpful in breaking this chain. Oftentimes that CBT will focus on money management, some of that cognitive restructuring. So beginning to see which thoughts are irrational and which thoughts are rational. Stimulus control technique. So trying to decrease the impulsivity that comes with some of the buying behaviors, as well as addressing motivation. Guided self-help, like we talked about with binge eating, can also be helpful. And those with significant comorbid mood issues, so severe depression, anxiety. So getting back to that central question that Dr. Bastin brought up, do you buy or do you gamble or do you use sex or do you eat to try to escape worry or mood or sleep issues? That is so important to being able to pick up on these behaviors and try to find treatment options for them. And in this case, SSRIs can certainly be helpful in relieving some of the mood issues related to compulsive buying. Next slide. All right, so one more, and that's the realm of sexual behaviors. So it's understatement of the century to say this is a little bit complicated. And it's complicated for a variety of reasons. So one is these questions. So is problematic engagement in sexual behaviors actually a feature of an independent disorder? Is it part of the impulse control disorders? Is it the result of a mood disorder or a substance use disorder? We think about sort of high rates of impulsivity in folks who are struggling with substance use disorders. Is that part of that? We also lack that same level of evidence that we see with, say, internet gaming disorder or gambling disorder, the sort of brain scans and the activity in different parts of the brains as a result of sexual behaviors. And so it's hard to sort of see just at the brain level, at the physiologic level, how much this maps with some of the other behavioral addictions. We don't know sort of what the diagnostic threshold is, depending on how it's counted, what behaviors do count. There may be more men than women with high rates of sexual impulsivity. And the other problem, similar to internet gaming, while that's been narrowly defined, this is a really big umbrella encapsulating masturbation, pornography use, anonymous sex, having multiple sexual partners, paid sex. So each of those themselves have unique and sometimes overlapping risk factors, treatments, and evaluations. Next slide. But maybe the thing that complicates things the most is the fact that the medical field has gotten this wrong before in a big way. A lot of sexual behaviors that exist on what we now know is a normal spectrum used to be medicalized or criminalized. Think about sort of the sodomy laws that were present in many of our states up until even just a few decades ago. And so we have to tread carefully when talking about these particular behaviors. Next slide. So there are a lot of mutual help groups available. And that's often sort of the besides CBT, something that I want to think about early on for folks who are struggling with these behaviors. They're usually modeled on 12-step programs. So the next step up would be an intensive outpatient program or inpatient program. But because of the lack of sort of clear clinical criteria, a lot of those are not going to be covered by traditional insurers. And so you're having folks pay a lot of out-of-pocket expenses for something that doesn't necessarily have proven evidence behind it. CBT it certainly has the potential to be helpful. And I think the main themes that you would want to center on for a client would be avoidance issues, anger, shame issues, and low self-esteem as well. There's not really any benefits from pharmacotherapy, and you can see why when we talk about the problem of cataloging and characterizing this group of disorders. They're really different. And so SSRIs, naltrexone, Others may be helpful if there's a clear other indication for the medication. But because of that problem with lacking a clear diagnosis and sort of the brain physiology studies that still need to be done, we don't have a lot of light at the end of the tunnel here for folks where this is a major issue, unfortunately. Next slide. So we'll conclude by going back to our island. So we started here, we talked about how if we're dropped onto an island, our physiological drives, the autopilot centers of our brain are going to kick in to get food, water, shelter, safety. But with us, with our behaviors, we're going to be able to acquire those things, but some of those behaviors are going to lead us astray. And we're going to keep on doing behaviors that might be potentially harmful for us because we start to see them as those physiologic drives. But if we think back to what is a behavior is our way of being in our environment, of learning how to be, right? We can also think about how changing that environment can change the behavior itself, right? So if we live in a society where some of these behaviors are less stigmatized, does that allow people to seek help? Yes. If we live in a society where we're kinder to one another and that we try to focus on sort of evidence-based therapies that are helpful, will these behaviors get better? I think so as well. If we're able to identify within our own patients who are struggling with a substance use disorder or an opioid use disorder, these behaviors as a result of coping with ongoing mood, sleep, and other issues, will they get better? I think so as well. Yeah, let's not leave the guy banging his head to try to get coconuts out there. There are other ways, and I think that the message that I want to send to all of you and that we'll try to emphasize in next week's discussion is that while these are really challenging cases because it's hard to pick up on and there's not always clear management options, I think there's a lot we can do. And so we won't try to leave them on their own island there. All right.